Well, class, this is the last segment of our lecture on best practices for nurse practitioners. That's my title for what we've been talking about. I have gone through and described healthcare informatics, what is informatics, what is data, and then how we're going to use the data to code nursing practice, patient's plan of care. And then the analytics that we need and what we get from using such a nursing coded terminology. This last section, I'm focusing on health informatics and your specialty, nursing practice. Now, there's very little in the literature about nursing practitioners and informatics, but I've been able to find a few studies and a few articles on this topic. We do use, and we have got one chapter or several chapters in the Essentials of Nursing Informatics by Saba and McCormick. We have a chapter on nurse practitioners by Dr. Lavin, who was an expert in this field. And I want to make sure that our lecture has been given so you do not lose your nursing practice identity. It's so important that the nurse practitioners keep your basic skills and your basic philosophy of looking at not only the illness the patient is presenting, but the whole patient. As nurse practitioners, you will be involved with health informatics, which not only impact nursing, but also your specialty. Your varied roles are similar to those of primary care physicians and practitioners, as well as advanced nurse practitioners. You can be found in hospitals, and at Georgetown, some nurse practitioners are acting as house officers. They're in clinics and as intake practitioners. Also, many are found in the storefront retail clinics that have emerged on almost every corner in the country, and others are still becoming independent practitioners with their own freestanding practice. The variation is so wide and so challenging to our specialty that we have really impacted the healthcare system across the country. Nursing practitioners' health informatics competencies require that you understand what I have presented in this lecture for nurse and non-nursing informatics. Also, that nursing informatics experts need to understand what is data, how is data translated into information, knowledge, and ultimately wisdom. Additionally, health informatics competencies are needed to communicate and manage knowledge, mitigate errors, and support decision-making competencies. That is, we need to address knowledge, skills, and attitudes, which are outlined in the following table. The table outlines the quality and safety education for nurses developed by the Institute of Medicine to address informatics competency for nursing faculty as well as for nurse practitioners, and is a document worth reviewing. It addresses 3 levels of informatics knowledge and skills. The first is why information and technology or informatics are essential for safe health care and patient care. The second is the value of common databases that focus on terminologies and data. And the third is the value of IT tools needed to provide effective patient care. Now, for each, there's at least one skill that's critical. The first deals with informatics education, focusing on data and how to manage IT. Second focuses on the use and the ability to maneuver and manipulate the electronic health records for your purpose, and how to design a multidisciplinary patient plan of care for them. And the third one deals with IT to manage decisions making that refer to the protocols for addressing electronic alerts, outcomes, and other care measures. It also stresses the need for nursing to have a positive attitude and to become computer literate. We find that many are still illiterate in this field, and it's not allowed anymore. We have to become with it, and we have to be in tune with the times. Another reason as to why the nurse practitioners were slow in becoming computer literate was described in a study by Aristo in 2014. She found that the nurse practitioners indicated several barriers to informatics and IT that they experienced. The major one being that the structure and content of the clinical decision support protocols in the EHRs were not adequate. She also found that there was a lack of educational training on how the EHRs and the software protocols impact on interoperability. In other words, she found that nurse practitioners need a great deal of information and a great deal of education on informatics. Another article by Mertz emphasized that nurse practitioners were focusing on 5 clinical decision support rights. Now, it's an interesting article, and it's something you should consider. They talked about the right information, that the nurse practitioner needs the right information. They need the right people, that is the IT support, to help them and teach them. They need the right format, that means the screens on the EHRs for usability, and then the right channels, that means talking about the hardware and software, and the right times refers to the alerts. The alerts being the key issue that seems to keep cropping up in all the electronic health records. So we have these 5 rights, we have these barriers, and we have the promotion and the push to make sure that the nurse practitioners are computer literate and understand the value and what informatics can bring to your field. So to summarize, I want to make sure that you understand that the EHRs vary from one vendor to another, which is hard if you go to more than one hospital. As a result, different systems use different models, structures, and frameworks for documenting patient care. In the original EHRs, most of the vendors tried to copy the paper chart and were not successful. Whereas today, then the vendors decided to design their systems based on the federal legislative regulations, using only code sets that were used to generate revenue in the hospital departments, and that they recommended only code sets for using for documenting patient care, coding progress notes, and interoperability. The interoperability of EHRs is still an issue, and which has not been completely resolved. The military have resolved it, but not the civilian hospitals. For example, the Epic system data are only interoperable with other hospitals that have an Epic system, and are not interoperable with hospitals that use Meditech or Cerner or any other system. So we have one big gap there. As a result, many patient care data sets cannot be communicated with other facilities, and making interoperability still a major issue in today's healthcare industry. That has to be resolved, and right now it is still going on. Now maybe it will help with the macro system not requiring specific services by code set, and maybe that will make it easier for everyone. Time will tell. This year, the macro legislation requires that only 5 measures be required. And every year, they're going to expand the number of quality measures that they want to use to code and pay for patient care services by practitioners. To conclude, even though federal legislative acts have been passed since 2000, and the federal IT regulations initiated were primarily aimed at improving access to data for clinical decision support, quality care, and outcome measures, the vendors are still not satisfied, and the users, hospital users, are still not satisfied with the vendors because they're too complex, documentation is too burdensome, and because I am furious because they have excluded nursing services care and coded care and their impact on patient quality outcome measures. Those are the new buzzwords of today, and those have been missed by nursing. For this reason, we recommend that you implement the CC system with its mapping to SNOMED to achieve the ultimate goal of data interoperability that supports excellent clinical decision support and best practices and generates quality and safety outcome measures and is usable across the continuum of any healthcare system. So with this in mind, I have to say that's the end of our lecture. I have given you a list of references, and in the slide that gives the website, it also gives an email address where you can always send me a question or a comment, and we will always love to hear from you. So with that, it's been a great, pleasant experience for me, and I hope you've enjoyed the lecture. I hope it will help you in your future role as nurse practitioners. Take care and goodbye.